Let's learn about Tetralogy of Fallot. It is the most common congenital cyanotic heart disease in children. Congenital means it is from birth. Cyanotic means deoxygenated blood is mixing to oxygenated blood. Means there is a right to left shunt. And of course it is a defect because there are valves and septum in the heart which are not normal in the Tetralogy of Fallot. Now tetralogy means there are four components in this defect. The most important component is large ventricular septal defect. Second is pulmonary stenosis. Third is right ventricular hypertrophy, and the fourth is overriding of aorta. The third component is due to the first two component, means there is a ventricular septal defect, there is a pulmonary stenosis, so the blood is filling more in the right ventricle, and due to that over the time right ventricle gets hypertrophied. Now overriding of aorta means कि aorta is directly present over the ventricular septal defect. Instead it should be present over the left ventricle ideally. So in normal people aorta transfers blood from left ventricle to body. But in Tetralogy of Fallot, this aorta overriding is transferring both deoxygenated and oxygenated blood to the body. So this was the four component of Tetralogy of Fallot. Now we will learn about the hemodynamics of TOF. So ideally left ventricle should have more pressure than the right ventricle. But in the case of Tetralogy of Fallot, due to large ventricular septal defect, the two ventricles become almost similar in pressure wise. Now during systole, the deoxygenated blood which is present in the right ventricle is not going appropriately into the pulmonary circulation due to the pulmonary stenosis. It leads to two things. Number one, very less blood is going for oxygenation in the lung. Second, it is increasing the pressure of the right ventricle chamber, leading the blood to transfer back into the left ventricle, which is right to left shunt. So now as the deoxygenated blood is transferred to the body, the tissue will not get enough oxygen, and thus the baby will have shortness of breath or breathlessness, which decreases partial pressure of oxygen, increases partial pressure of carbon dioxide, and also increase pH, which will lead to stimulation of central nervous system to increase the breathing rate, which is called hyperapnea. Hyperapnea stimulates sympathetic system to increase venous return and also tachycardia. It leads to more blood filling in the right side of the heart, which finally leads to more right to left shunt in the TO of baby, which increase the cyanosis of the baby, and the baby looks blue. This is called cyanotic spell in the Tetralogy of Fallot. There is one more reason for cyanotic spell. So when the baby cries, it decreases the systemic vascular resistance of the baby by dilation of the peripheral arteries, which leads to overall decrease in the pressure of the left side of the heart, because left side heart pressure is decided by two things: left ventricular systolic contraction and systemic vascular resistance. So due to decrease in the left heart pressure and increase in the right heart pressure, which is already mentioned, there is more right to left shunt, means there is more deoxygenated blood coming to the systemic circulation, which will increase the cyanotic spell of the baby. So this was the most typical clinical feature of the TOF baby. Talking about the other sign in the case of TOF baby, so auscultation funding. There is a no systolic murmur as the right ventricle and the left ventricle pressure is almost same due to increased defect in the septum. Ejection systolic murmur may be present, but it is inversely proportional to the severity of pulmonary stenosis. Why? Because more severe pulmonary stenosis means very less blood is going, so there will be less murmur, and less severe pulmonary stenosis means more blood is going from right ventricle to pulmonary artery, means there is a more murmur. Now talking about the heart sound, because of the low pressure in the pulmonary artery, P2 is soft and often inaudible. So S2 will comprise mainly of A2 only. So in the chest X-ray, we will see boot-shaped appearance because of the right ventricular hypertrophy. There is a no heart failure in the case of TOF because there is no over or increased volume in the right ventricle or the ventricles, because the blood in the right ventricle is transferred to the left side through aorta to the body. So there is a no over volume. So there is a no CCF. Now come to the treatment part. So it is of two types: medical treatment and surgical treatment. Surgical treatment is permanent, but medical treatment we give for decreasing the cyanotic spells in the baby. So for decreasing the right to left shunt, this is how we will decrease the cyanotic spell. So we have to target on following thing. As it is hypoxic condition to the tissue, we can give moist oxygen to the baby. Second, due to increase in the pH or increase in PCO2 concentration, hyperapnea was occurring, so we will give bicarbonates to decrease the H plus concentration. Also, to decrease the hyperapnea or increase breathing rate, we can give morphine, which depresses the respiratory function. Also, we can increase the left side pressure so that there will be decrease in the right to left shunt. This we can do by increasing the systemic vascular resistance. This we can do by giving vasopressors like phenylephrine to the baby. Also, we can decrease the tachycardia by giving beta blocker. There is one more interesting maneuver which the baby learn by itself, squatting. The TOF baby learns to squat often because it decreases venous return by pulling of blood in the lower body. So by decreasing the venous return, there will be decrease in the right to left shunt. So by itself the cyanotic spell decreases. So most of the TOF baby, they often squats, or there is a thigh to chest contact. The final treatment is surgical treatment, but the baby should be prepared for the surgery. So we do two things: stenting or shunting. Shunting is little temporary. So in shunting, our goal is to mix the blood, means increase the pulmonary circulation. So we will do it by shunting between the pulmonary artery and the subclavian artery. So it is called Ballock tossing shunt. There are similar shunt, but the main goal is to attach the pulmonary artery to any sided artery, so that there will be increased pulmonary blood flow. So this was the temporary surgical intervention. Permanent surgical intervention is balloon pulmonary valvuloplasty. So we put the catheter moves towards the pulmonary artery, then we will either expand the balloon so that the stenosed part is now dilated, and there will increase in the blood flow in the pulmonary artery. Second, we treat the BSD by patch. So this was all about the tetralogy of Fallot. Thanks.